So I just turned on my microphone. Yep, it's on. I think, yep, if you could verify over there, I have everything on here. Um, and this is great. We already have 99 people online as well, and 99, and we have the big room today as well. So already a well-attended grand rounds. I was just saying I usually try to start at 8:32 because that allows people to filter in, but we already are over 101, so that's great. So we're going to get going today. The theme for the grand rounds today is building bridges in healthcare. We're going to have introductory comments from our CEO at CHEO, Vera Etches, and our CEO at the CHEO Research Institute, Jason Berman. Really briefly, it's a really big need in our health system broadly now to connect care better for people who need to access care. And we still exist sometimes in siloed provider systems within our broader healthcare system. And all of us, I think, have a desire to figure out how to work better together and how to connect all of those pieces. That's all the introduction I'm going to give. As I mentioned, Dr. Vera Etches is our CEO at CHEO. I'm going to introduce her first. Dr. Bill Hogg is a scientist, a professor, and a senior research advisor in the Department of Family Medicine at the University of Ottawa, and he's also currently the chair of the Department of Family Medicine at the University of Ottawa. His research program focuses on improving primary care delivery by developing methods to measure clinical performance through automated patient experience surveys. Using appointment schedulers and EMRs, patients receive survey links via email or text after visits, reducing data collection costs and supporting research accountability and quality improvement. So that whole concept of mobilizing health information, including that reported by patients and integrating it better, is something that's been elusive also in our health system, but we're making strides. If I remember back to my time at Bourne, Ontario, and I tried to have people from Bourne participate or join virtually today as well. How can we do this better? So Bill will come up after Vera and then introduce our next speaker.
Well, this is.
The land acknowledgement.
Do you want to do it? Okay. Sure. All right.
In all of my excitement, I forgot the land acknowledgement, which is vital. So Ottawa is built on the unceded Algonquin Anishinaabe territory, as reflecting on the concept of unceded today, and I think that is important to note. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Now I'll hand over to Vera.
Thank you. It's funny, like there's this small little dot of a camera here, so I won't move around too much, but it is nice to know that there are people behind the screen. And I thought I would just start with our shared vision. We're both here as family medicine. Actually, I mean, maybe I should say all here. I think there are community pediatricians joining in today, CHEO people, research-minded, because we want to improve the health of children and youth. And, I think that's where we all start, and we all have different contributions. And I think what Pranish alluded to is sort of our current state today is pretty disconnected. I think I could just take the example of what we feel today in our emergency department, the number of children presenting with respiratory illness, knowing they don't all need to present to an emergency. It's not all urgent care, but people don't know where else to go. They don't have another option. Family medicine is such a crucial foundation that we know we don't have enough of in our community. And so I think that what we're interested in is building towards that future state. And I love the title, Building Bridges. That's exactly what we need to do to get to that future state where care is connected. And, I think certainly some of the current challenges, people see the waits, they see the difficulty accessing, but I would just also say, like, we know part of that is CHEO, right? That people have difficulty accessing the specialists at CHEO and getting information about what we see that could help inform the community. I think when we think about building bridges, there are a couple ways we can do that. And to me, the most important is building relationships. So I'm really thankful for everyone who's joined today, because getting to know each other, getting to understand what is our common vision, where are the potential pathways, and how can we each build bridges is really important. That relationship building truly is the foundation. And then you'll hear today, I think, also about how technology and some of the other tools that are continuing to develop will also help us build bridges. So I'm quite optimistic about the future. I think the other bridge that I'll allude to briefly is research. So coming into the hospital sector from the community, it is striking how difficult it is to maintain our operations with the resources we have. From the outside, it seems like hospitals have all the money, and I'm sure, relatively speaking, we have a lot of capacity, but we have a lot of pressures just to keep the infrastructure going. And you think about, it's really underlining to me, this is not a sustainable way of running our health system. The dollars that it takes to keep something like this going, we need to think differently, and research will help us. Research will really show us what else can we do in terms of care pathways and partnerships. And there are so many people already demonstrating parts of this. So when you think about that respiratory illness, we have wonderful things happening with asthma care pathways. Community pediatricians are involved in sort of triaging who needs to be seen where. How do we support education for those who need it? Like there's definitely elements that are so strong, and when we can research that and evaluate it and demonstrate what's working and showing better outcomes, that is a way to shift systems. So I think that's something Jason and I have been talking about, is how do we make research part of everything we do. Even as we're building these bridges, we need to study that and evaluate that. And other pediatric systems exist where they are more integrated. And you think about in the United States, there are examples, pediatric hospitals that have built housing. They set up urgent care. We're not going to be the same as that, right? We're not, as CHEO, trying to ourselves build the system. It's collectively, it's work. We don't know exactly what that should look like. We need to do it together. Primary care, community peds, patients, families, public health, right? So we're quite excited about this opportunity to continue to build those relationships and mechanisms to co-design a system that works better. Certainly, we're also thinking about the city and housing and social supports for families. We know pediatrics is different. We talk about what do children need for well-being. It's not just health care. So we're thinking big, and we all need to be part of it. So I guess just really want to recognize we are interested in new ways of doing things. We're really happy that you're joining in the conversation. Today is about one particular kind of opportunity, but the intent of starting this work and having rounds where people come together is to work on that bigger vision, so that we will get to a place when the newcomers who currently are in our emergency department actually, they've had contacts in their neighborhoods with the community engagement team from public health to help them get their vaccine. And they've got the right language indicated, so when they access services, it's easier for them to understand what's needed. And we have new hubs for urgent care in our community, east, west, south. Maybe the community pediatricians are running that with support from primary care. CHEO psychologists, right? We've heard about the burden of mental health, and there's just so many things we're excited to keep building with so many community partners. That's all I wanted to emphasize today. I'll pass it over to Jason.
Thanks, Vera, and good morning, everyone. It's a little bit weird, right? Because you're talking, sort of talking into a dot. But, I'm delighted to be here. And, Vera's comments were a great segue, because I was going to begin my comments by saying, where does the Research Institute and research fit in here? And I think it is sort of fundamental. So today, I would say, is both a culmination and a beginning. So it's we came to today from a dinner meeting that Bill and I organized in the summer. Hard to think back to then because we all sort of arrived sweating because it was so warm out, and today we're all like shivering because it's so cold out. But where we looked at, we had a number of leaders from CHEO, from the Research Institute, from the Department of Family Medicine, and really did a bit of a think tank around the challenges that we're facing. And, Vera touched on this in the fact that research in our current CHEO strategy is meant to underpin everything that we do. We know that evidence should inform best practice. We know that today's care comes from yesterday's research, and today's research will inform tomorrow's care. And, while we tend to think within the walls of CHEO of being sort of a tertiary institution, subspecialty practice, subspecialty research in various different disciplines, we know that CHEO is much more than a hospital. It is an entire system of care, whether we think about, palliative care that's provided, we think about autism services, we think about the CHEO school, we think about One Call, One Click, we think about all the partners in Kids Come First. And so CHEO really functions beyond its walls. And we know that we serve the community well beyond Ottawa proper into eastern, all of eastern Ontario and northern Ontario and western Quebec and up to Nunavut. And that's really where the Research Institute, that's our same catchment area. And so we really want to bring research from within the building beyond and provide research in the community because that's where the patients are. That's where the families are. We want to bring research there, and we want to be a facilitator and enabler of that research. We know that many primary care providers, Bill is a very experienced researcher, but many in primary care don't have research background but have great research questions. And so how can we work together to help solve those questions and apply the typical tenets that we have in research around hypothesis generation and testing and troubleshooting and iterating to be able to find the best solutions. One of the pillars in the CHEO Research Institute strategic plan is transformative collaborations. And while we may think about that as regards to international collaborations, and of course we're working on those, it also means transformative collaborations at home and how do we build those bridges with those in our community to deliver care. I'm very proud that the Research Institute has stepped in a number of circumstances to help support activities at CHEO and to meet needs, most notably during the COVID pandemic, where we had researchers pivot to use RNA testing, and Alex McKenzie is in the room to look at wastewater as a biomarker, using wastewater as a biomarker for COVID-19. We did research on mask decontamination. We worked to stand up vaccine clinics. So we really served the community and provided a research lens to be able to answer those questions. And, we're now faced with another crisis. All you need to do is walk down the hallway outside our emergency room, and Vera alluded to that, to see what the number of patients and families that are waiting. And so, we are in a primary care crisis. And so, again, let's have that research mindset to step in and try to solve these bold and thorny problems. And with that, I'll turn it over to Bill.
Good morning. Yes, indeed, we have ourselves a primary care accessibility crisis. In its own right, that is a disaster for over 200,000 people in our district. But it's also a huge problem for you as pediatricians. I know that if you don't have someone to discharge a patient to, it completely gums up the works for you. The emergency room, waiting, the being jammed 24/7. It's a huge problem for us all because, in fact, it's a system. So we in family medicine can't solve this by ourselves. We need help, and we certainly need help from CHEO. Today we're exploring what might be possible together. And I hope people will feel comfortable in contacting us with their ideas. As Vera alluded to, we're really trying to cast a broad net. I want to be sure to explain in the rest of this rounds, we're going to focus on a specific example, but that's mostly an example to inspire people about what's possible and to share with you the kind of things that we're hoping to do together. So, but our biggest priority for today is to hear from you things that you feel that we could win together. And I guess very pragmatically would encourage you, because the Ontario government has recognized that there's a huge problem and is investing in it. So I'm sure you've heard of Dr. Jane Philpott and the Primary Care Action Team. So the government has committed to spend $2.1 billion trying to make it possible that within 4 years that every Ontarian who wants one will have a primary care provider. So we can dream here and think big. And if you haven't already heard, you will be hearing in the next weeks or so that the government will be funding a brand new primary care teaching center. It's likely to be located in Vanier or Lowertown. And it's going to have services, probably, we believe, social services co-located in the same building. And we'll be training nurse practitioners, family doctors, all sorts of primary care workers. And we want, pediatrics to be there with us. Tell us how you think you might want to do that, because right now we're listening. We're going to move forward now to talk about a specific example. It's not that firmly settled. It's settled enough that we hope it'll give you an idea of what might be possible going forward. But we can't do it without you either. And we are inviting you to sort of co-develop the idea in more depth. So let me introduce Dr. Kamila Premji to you, as she will be presenting this example. But first, please let me say, nous ferons notre présentation en anglais, mais si vous avez des questions ou des commentaires et que vous êtes plus à l'aise en français, n'hésitez pas de vous exprimer dans cette langue. Si vous ne comprenez pas quelque chose, n'hésitez pas à nous interrompre et je vais traduire ce qui était dit. Okay, so Kamila. Kamila Premji is a family physician, an experienced family physician here in Ottawa, working in a private practice downtown. She's an assistant professor in our University of Ottawa department. She recently completed her PhD in family medicine and is the Physician Services Institute Knowledge Translation Fellow. And even more recently, was awarded a clinical research chair in universal access to comprehensive primary care. She's held leadership roles at regional, provincial, and national levels. In clinical practice, she's providing comprehensive primary care to patients in a diverse, densely populated urban region of our city. I could go on, but why don't you, I'll stop and let you take a...
I'm getting a prompt to approve a recording. Yep. Oh, I pressed approve. Great. Thank you. Good morning. I'll try to go on my tiptoes to see over the laptop there. So thank you, Dr. Hogg, for the introduction. Thank you, Dr. Etches, Dr. Berman, and Dr. Chakrabarty for bringing us all together here today at CHEO, and to all the family medicine colleagues and leaders who are joining us today, thank you as well. So I'm thrilled to be presenting this project, which we've called Facilitating Efficient Primary Care for Babies and Children. As Bill said, it's one of several interventions and ideas underway in the community to help strengthen pediatric care, and we see this as a fantastic opportunity for CHEO and the DFM to collaborate and make a difference for both clinicians and patients, and it's just one example of how we can do that. So the motivation for this project is twofold. The issue of pediatric patients who have no attachment to a regular source of primary care, and burnout in the primary care sector. So in other research that I do with a different team, we've identified that over 14% of children in Ontario do not have a regular source of primary care. So that would be either a primary care pediatrician or a family doctor. And we know as well that pediatric care can be time-consuming and resource-intensive, and it may potentially deter already overwhelmed family physicians and primary care pediatricians from accepting newborns and children into their practices. And certainly anecdotally, I hear from colleagues who are so over capacity that they are no longer even accepting newborns of their existing patients into their practices anymore. So when we have a strained, burned out primary care sector with limited capacity for new patients that's resulting in newborns and children being unattached, there are obviously potentially significant population and system level impacts of that. So we are concerned, for example, about the impacts on our community of delayed or missed immunizations, of delayed or missed screening like developmental assessments, referrals to specialists for conditions that could have been managed in primary care if the patient had a longitudinal comprehensive primary care source, and ED visits that could have been averted if, again, the patient had a longitudinal comprehensive primary care source. So our hypothesis is that we can leverage AI-based technology to improve the efficiency of care for babies and children, and that by making the workload of pediatric primary care less daunting for family doctors and primary care pediatricians, more will be willing to accept newborns and young children into their practices. And we hope that there would be a retention effect as well. People feel less burden in their practice. They may stay in the workforce longer than they initially thought they would. So our intervention involves two automated burden-free technologies that will be integrated into primary care practices. The first is an appointment reminder technology that pushes preparatory information and a history collection tool to the patient ahead of or their parent ahead of their appointment. And the second is linked to an AI scribe that can auto-detect and integrate educational information into a patient-facing visit summary at the end of the appointment. We plan to focus on well baby checks initially for children age 0 to 4. These appointments can occupy quite a bit of capacity in primary care because they're frequent and they often are quite intense. There's a wide range of topics to cover and a wide range of questions to ask and to answer. So there's potential to make a real meaningful difference here in workload for clinicians if we can make these types of appointments more efficient. So, of course, this project is going to require a broad range of collaborations to succeed. So we're thrilled to be welcoming members of CHEO and the DFM to this study. We're also collaborating with the creators of the Rourke Baby Records, so Drs. Leslie and Jim Rourke, who are here today. I'm a little starstruck. And CHEO's own Dr. Anne Rowan Leggett, who's also here today. And these collaborations will help us make sure that on the patient-facing side, the intervention is safe, it's low burden, it's useful, and that on the physician-facing side, the content is evidence-based and it's consistent with the Rourke Baby Record, which has been extensively researched and very solidly grounded in that evidence. We've also collaborated with vendors. So we already have on board 2 vendors who are already integrated into clinical practices and who have the capability of developing, implementing, scaling, and spreading the technology and ensuring, especially importantly, that the intervention is seamless, efficient, burden-free for primary care physicians. So how would this technology unfold in the real world context? So let's take a 6-month well baby appointment, for example. So prior to the appointment, the automated AI-based appointment reminder technology detects the appointment is coming up in the schedule for the physician. In 2 days, 3 days, the setting can be adjusted. And it pushes the preparatory information. So for example, at this appointment, your child will be due for this vaccine, and also collects the appropriate history. So for example, developmental milestones, information on sleep, feeding, and so forth. Then at the appointment, the technology has already entered all of that information into the patient record, so it's ready for the physician to look at. And the parent is also prepared about what to expect from that appointment. And then at the end of the appointment, the AI scribe technology generates a physician note, as it typically does. Many of you may already be using this technology, and develops a parent-facing visit summary tailored to what was actually discussed in that particular visit, not a boilerplate type of summary. And embedded in that visit summary is expert-generated education and counseling information that was tailored, again, to the visit. So, for example, if introduction to solids was discussed at this appointment, there's going to be information that is expert-generated attached to that patient-facing visit summary. So we're starting with the well baby checks, but that's just a starting point. We see the potential to really expand this to include other common resource-intensive types of pediatric primary care appointments, so things like asthma, eczema, ADHD. We're really eager to hear actually from the pediatricians and other family doctors here today about what your pain points are, because as Bill said, this is in the early phases of development, so we have a real opportunity here to co-develop our priorities and the patient resources with CHEO and with our family physician partners as well. So when it comes to priorities, there's an opportunity to co-develop the outcomes of interest. So making sure that we are aligning with the pain points across primary care and CHEO. And since we haven't finalized the outcomes yet, but we've put a list of potential primary and secondary outcomes here. Again, open to hearing input on what matters to you, so we can tailor the outcomes that we study accordingly. So where we're at right now, currently we're tackling a needs assessment and planning out a feasibility study to test and tweak the technologies, integrating them into existing practices. And then we plan to apply for funding this spring to conduct a larger pragmatic cluster RCT. And our goal is eventually to scale and spread this across Ontario as well as across the country, starting with regions where we've already partnered with clinics on patient-facing digital messaging. So I'll stop there and then open up the floor for discussion. And I think somebody is monitoring the online audience as well for any questions that come through there. So feel free to ask questions online as well. The purpose of this is to help make the clinicians' lives easier, less burden-free, and while also providing something useful to the patients and the parents. It is not meant to add to clinicians' workload. It's not meant to overwhelm parents. Thoughts on this concept are welcome. How could it be improved? This concept that we're presenting today, how could it be improved to help you better in your day-to-day practice? And what are the other primary care pain points in pediatric care that our intervention, from your perspective, could actually help? And I'll put this up as well. And shamelessly, I've put a photo of my niece here, who's 3 years old. And also an inspiration for wanting to improve pediatric care. So our email addresses are here, so feel free to reach out to us as well if you have any questions after the presentation. So thank you, and please feel free to ask questions.
So thank you very much. I'm going to here just pull open the chat and maybe pull down the slides. Rachel, maybe we can take the slides down so that we can also see people who are virtual. Um, uh, Sorry, I got distracted at the very end because that's a great picture of her, and all I could see was the made in USA on the swing. I was like, you got to put a cross out through that, and yeah.
They live in New York. Actually.
Okay, so that's okay then.
We're trying to get them back.
I'm still having my elbows up here.
Yeah, we are trying.
We'll start. I saw Rob, who's a pediatric nephrologist here in the room, has a question, and then we'll monitor the chat as well. And then I have a couple of questions, hopefully to get things going as well.
Great.
And if you stand
I'll
here,
try to stand in front of the dot.
because of the dot, and then
yeah.
Okay.
we're just. We can start with your question, Rob.
Yeah,
And
okay.
again, with the setup in here, you'll have to repeat Rob's question.
Sure.
Okay, so that people can know what that was.
So
Go ahead, Rob.
Yeah, thank you very much. This is a great endeavor, super important, and I think everyone in the room and online will acknowledge that. So it's really wonderful. My question is around the pushing of information to the patient, I guess to the family. So this is going to be an automated process where the family will somehow receive something on their phone. Is that correct?
Yeah, their phone or their email.
Or their email.
Their desktop email.
Okay.
Mhm.
One of the questions I have is when I'm walking around CHEO, I'm seeing so many children coming here who are who don't appear as sick as I would expect if they're waiting hours and hours to see an emergency physician, for example. And I wonder, I was talking to my wife this morning about this, I wonder about a way to send messaging to the community about how do we dissuade away? Yeah, how do we dissuade people? And I say this very carefully. I really want no one to think I want people to avoid care if they need it, but could you use this technology to send out a feeler around the time of viral season to say, if your child has these symptoms, please come. But if there are these symptoms, is there a way for you to try to manage that home? Something,
Yeah.
I'm a nephrologist, so I'm
Yeah.
dressed the same way at primary.
Oh, it's a great question, and it speaks to the
So if you can
potential.
first kind of try and
Sure.
summarize it
Sorry.
again.
Yes, your question.
We'll have to get microphones in the room.
So Rob's asking whether this technology can also be leveraged for other purposes, like to push out mass messaging to parents about when to recognize that their child needs to be seen in the emergency department versus not. We hope that we will alleviate some strain on the emergency department simply by freeing up capacity in primary care. So for those who do have a primary care clinician, they will be able to better access them. But yes, it is a challenge to convince people to stay away from the emergency department sometimes. And you're right, it's a tricky balance between, keeping people away who should stay away and inadvertently deterring those who actually did need emergent care. And I think this would be a tremendous opportunity to collaborate with CHEO and the pediatric experts on how that messaging should look, because yes, this technology does have the capability to do that and to automate that process too. So, starting, the beginning of the school year, make sure your kids' vaccines are all up to date. Starting, the beginning of cold and flu season, here's where you can get your flu and COVID vaccines and your RSV vaccines for the littlest ones. So we actually do have a project that is tackling the issue of climate change and the health effects of climate change, where we do exactly that. We send mass emails ahead of heat waves, at the beginning of the summer to say, here's how you can prepare for heat. So yes, I think that's a great idea and a great example of how we can collaborate to create that messaging and deploy that messaging at the right time.
Yep. Thanks. Maybe I'll ask a quick follow-up. One of the things that comes up around any AI-generated messaging, especially around advice to people about their own health, is the performance in terms of having accurate messaging. And so if I think of Rob's question about messaging that might be generated to send out to families, but then also in terms of risk, and that's primarily risk to the patient, but also risk to the system or to the provider. So I was curious, the same question came up for me in your summary in terms of the AI generated note. In some ways it can reduce burden, but it also can increase burden for the review that's necessary to ensure that the physician is actually okay with everything that's being suggested. So I was curious how that was going to be built in, either as an outcome measure or as a comparative intervention in your study.
Yeah.
So both Rob's question in terms of risk and accuracy, and then also in your study, how were you thinking about this?
Yes, so the content that will be going out to parents based on what was discussed in the visit, so the health information around, say, colic or feeding and things like that, is expert generated. It's not the AI that's creating it from scratch. Eventually, we foresee, as AI improves, there's an opportunity for this to be completely driven by AI. But the moment, and especially to ensure that, as you said, the clinicians trust the intervention to be safe and effective and to not create extra burden for themselves, it will be expert generated content. So it will bring into the patient visit summary from a library that we have created that has been developed by an expert team of professionals on a variety of topics. It will be pulling from that library expert generated, physician approved content so that the clinicians who are using this intervention can trust that that the information is accurate and up to date, and that they're not giving the parent information that's going to cause harm.
Great. Thanks. And what I think I'm going to do, because we have people in the room, we have people putting their hands up for live questions, and for anyone in the virtual room, I'd encourage you, if you want to, just say your question, we can put you on the screen and hear your question. And then we also have questions in the chat. So I'm just going to circulate between those, okay? So the next one, I'm going to go to a hand up. First one is Kelly Zwicker. So if you can, come on. There we go.
Thank you. This is a lovely session, and I'm really excited about the work that you're doing and how it can implicate your practices and our practices in general. And I wanted to highlight a question about the RORC and the ASQ. So in some pediatric practices, we are able to get consent through Ocean for using the AI scribe, as well as receiving SMS messages or email messages. And so once we have that recorded in the chart, we then proceed to send an ASQ virtually, digitally. We find that sometimes the parent may not answer all the questions, or we still need to go through it with them. But there's some lived experience with some of that messaging. And I noticed in the chat from Dr. McDonnell as well, there's a question about whether you thought about using the ASQ or other developmental screenings. And I just wanted to thank you for presenting and telling us about this work.
Thanks, Kelly. Great to see you, and thanks for the question. So this is, again, an opportunity where I think the involvement of people who are in the community living this reality would be really helpful. So people like yourself, we would love to be able to co-develop this with your experience in mind, so that we address some of the challenges that you've already encountered by using technologies that push information and questionnaires to parents. We think it can be improved. We plan to work closely with Dr. Leslie and Jim Rourke, with Anne as well, Dr. Rowan Legg, to make sure that the information that gets pushed out is patient-friendly language, that it is, safe, that it does help us flag where the areas that require further discussion are. It won't be just a yes/no kind of thing, so that we inadvertently miss areas where there's discussion needed. But yeah, we would need to, I think we do need to sit down with people who have the experience using such technologies already to see how do we make it better and address the issues that you have right now, so that the entire intervention is an improvement on what you're already doing. Thanks.
Okay, thanks. And I was wondering if Heather's question might be, did you already address Heather's question in the chat? Because I was thinking it might make sense to go to Heather's question since it's been referred to. And then for people in the chat who are above Heather, that's okay, we'll get back to you.
Hi, I've unaudioed. I don't have video. Thank you very much for your presentation. So that did dovetail well with Kelly's. So now the ASQ inventories are Brooks Publishing, which is proprietary in the US, right? Anyway, but including some developmental screening. I know there is a bit in the Rourke, and maybe a lot of offices are using Nipissing. So I'm a consultant pediatrician in the hospital, but even if we send it beforehand. So I think you've probably addressed it. Thanks, Pranish. But, looking at, because 0 to 4 years, you said first, or 0 to 4 months? I mean, there
4
might
years. Mhm.
4 years. Yeah. So at those visits, I would just endorse that. I think that would probably make things faster. But as Kelly mentioned, so this is just a comment. So as Kelly mentioned, you usually have to go through it with the parents because there's some grain of salt, either they're overestimating or underestimating the child's abilities.
Yeah, so developmental questions, we definitely envision that as part of the information that gets pushed out ahead of the appointment, part of the history collection that gets collected ahead of the appointment. And we would want to co-develop with the experts exactly how to frame those questions so developmental delays are not missed. And how to structure the answer choices, right? So if it's just a yes, no, then we might get yes, 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 yes as just automatic answers from the parents without necessarily thinking about it. But if we have an I don't know, or I'm not sure, or I want to discuss this further with the clinician, with my family doctor, with my pediatrician, then we have, some flags already ahead of the appointment of where we might need to focus the developmental assessment part of the visit.
Great, thanks. I think the next in-house question was actually Alex McKenzie, and then Tom Kavesi is next in the queue.
Talk. Using Scribe and getting patients to download information beforehand, it's been used a fair bit already to some extent. The idea of leading in a bit and getting an AI-generated oximetry and pulse, respiratory rate, and saying as they arrive after the first 5 minutes, you actually can go home now. Here's a WhatsApp, here's a video thing that you can call within 24 hours and really sort of head them off at that stage. And I know that Roger is here and Tom Kavesi's here, so they'll have strong opinions, I'm sure. But something along those lines, would that be something you guys could explore?
Just before you summarize, are you thinking in the primary care setting or?
Primary care or the door of the emergency? I just whether you can use metrics to prognosticate sending home or not.
Yeah, I mean, I think it's a great idea. There's so much potential for technology to help alleviate strain, alleviate capacity in so many different areas of medicine, and this could be one of them. I know in NICUs in Australia, for example, they're using AI to monitor vitals of admitted patients so that they can detect, there's a slight change in their temperature and a slight change in their heart rate. This kid might actually be on the verge of sepsis. So AI has tremendous potential. We are starting small here, but like I said, we definitely want to expand this eventually to other conditions. So to your point about, taking some vitals, if we expand this to asthma, could we do this slightly differently so that the technology is more tailored to that type of appointment and maybe, yes, helps head off, use of resources that may not be necessary. Yeah.
Yeah, thanks. And part of the reason I asked for the clarification on the question, again, with the theme that we're talking about overall in terms of connecting care better between providers, between institutions, for patients, with all of these, it's easier to think of them in silos. It's sometimes harder to think about how they all connect. So, to the extent that we can keep that in mind in the discussion, that's part of what we're trying to do here. Think outside each of our own buildings. Yeah. Okay, so I'm going to go to the next hands up question. Actually, you know what? I'm going to go next to the chat because there's a lot in the chat. Okay, Nancy Young, is there any thought to integrating measurement-based care into this system? Great question.
Hi, Nancy. So do you mean like incorporating home measurements that the parent would take at home, or measurements that we are doing in the office and then providing information to the parent based on our interpretation of what those measurements could mean, like if they're falling off their growth curve, for example? I just wanted a little bit of clarification to make sure I answer the question you're asking.
Yeah, sure. Thank you. I can't turn my video on, guys. Sorry, it's somehow blocked, and my voice is croaky today. But I think this is a great opportunity to be able to push some evaluation tools, some developmental assessments home so that when they come in, you have already half of the picture in front of you and you know where to focus. And you've already addressed some of that, which is great. And I think the Rourke charts are a fantastic example of how to formulate results from these measures. There we go. I think I got my video on. How to formulate these results in a way that give instant and quick meaning to families. Like families can look at a Rourke chart and at least after the second time they've seen it, they're like, I get this. I know what this says. So I think that's a really important thing to keep front of mind. But is the plan eventually to be able to integrate a bunch of metrics, obviously excluding the ones that have copyright and protections on them? But is that part of the plan?
Yes. So short answer, yes. We are looking to do that as part of it, and we are also looking to shape, the way that the Rourke is presented to the patients and the parents in a way that allows for easy interpretation across a range of levels of literacy, education, maybe eventually language concordance. All of this are areas of potential for exploration for sure, and that I think you're right would be very helpful to integrate into this work. Thank you for that thought.
And I always dream in Technicolor. You're doing great. I'm just thinking about what comes next. So yeah, do what you plan. Thank you so much.
Thank you.
Thanks, Alicia. Over to you.
Hi, can you hear me?
Yep.
This is just wonderful, and thanks, Prenish, for flagging actually the content of this rounds. It's been, I think, there's just amazing alignment between the work that we were thinking about at Born, where we are thinking across system and how we leverage information from various aspects of our across sectors to bring this data together. One of the things that we've been starting with and our plans were in the prenatal space to do something very similar to enable clinicians to be able to access information that we have at the registry that also can add to that evidence base of care of what's appropriate, what should be done now, et cetera, and also engaging the patient in that. So I just see so much alignment. I think this is an excellent presentation. I'd love to connect further on this. And maybe similar to the question that was just raised by Nancy, are you thinking about other ways or other information sources, maybe not as a first phase, but as a next phase that would be integrated into this type of a solution in pediatrics? And if you are, what are some of those?
Yeah, so thank you for the comment. We haven't thought too far into where other data sources could come from, but we know there's lots of data collected through other entities. So, for example, ICES. There's also practice-based research networks that provide their EMR data to a centralized database that is now being linked to ICES. There's tremendous potential to synthesize data from across multiple data sets and have it all concentrated in the primary care record to improve care. As far as the Born project is concerned, I just learned today that Born is looking to incorporate the Rourke baby record into the Born registry, so content from completed Rourkes in the EMRs, and so we could also be feeding into other databases information that we're gathering in this fashion.
Yeah, would welcome chatting with you more about that.
Great. I'd welcome that as well. Thank you.
Yeah, thanks. Thanks, Alicia. And Alicia and I, when Alicia used to work at Born the first time, and I was the medical director of Born, I think this was like 12 years ago, we were looking at exactly this, but we weren't there yet in the ecosystem. I think, things may have changed now as well in terms of readiness. I'm going to take the liberty of just asking one follow-up question. And maybe with the Rourkes here as well, it may be an opportunity to incorporate them into the discussion. I remember working with John Kearney around that time, who was a psychologist at CanChild, and looking at different age-normed tools for developmental screening at a population level. And some of the work that he was doing was really looking at measures of parental concern as opposed to age-normed developmental screeners. And it really piqued my interest because parental concern can arrive from so many different places, but can be an early indicator of something needing attention within the healthcare system. So I'd actually even thought about, could this be the basis of a population screener? And my background in newborn screening is partially what informed that thinking. So I was curious about parental concern tied to age-normed measures, and whether there's, in terms of primary care delivery, whether there's a a role for that you've been considering? And if not, I think looking at some of John's publications around this might be really interesting.
Yeah, thank you for that. I will look at those publications for sure. It's a really interesting idea, and I'm sure we all have this experience as clinicians where, you know, the check boxes all line up well. Everything is yes, 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 yes for all the developmental norms, but the parent is saying something's just not right, and we need to pay attention to that. That's quite nuanced, right? That happens in the exam room usually, but perhaps we could be collecting some information to flag for us. This parent is concerned, right? There's there's the opportunity when we push out the developmental screen for there to be a question that says, do you have any concerns about your child's development? Do you have any concerns about your child's health? And then we are primed when we go into the appointment. The patient is also activated. They've now organized in their head the things that they want to talk about at their appointment, which may also help with the efficiency. So yes, I think it's very important for us to pay attention to those cues that come from parents who know their children well, who might be comparing their child to their older sibling or to other kids in the community and noticing something is not just quite right. And there's nuance there, but we see that this technology does have the capability of integrating that into the parent-facing information and questionnaires.
Yeah, thanks. And I think his tool was called the Early Years Check-In. And my use case was, could it be a trigger to provoke a genomic screen? So even connecting out further was part of the thinking. Tom, you're next, and then we'll go to Lee Donahue, and then we'll go to the next chat questions.
So I'm a respirologist. I also have a looking ahead question. I guess both questions have been. So there's a study from Quebec that 70% of Canadians with asthma, Canadian children with asthma, are on PRN inhaled steroids, which are useless. And half of that's driven by the families taking their medications only PRN, and half are because the community physician said, take this medicine only when you're sick. So my question is, do you see the AI not just prompting parents, but also prompting the community physician with evidence-based advice? So if the physician's going to say, okay, I want you to take this only when you're sick, something comes up that says, really, you should take this all winter.
Yeah, it's a great question. We've thought about exactly asthma, actually. Yes. So the question is, can this tool or can this technology be used not only to push education and counseling information to parents, but also to help educate the clinicians in the community who might be prescribing based on outdated advice? So, for example, inhalers for asthma. We've actually talked specifically about asthma as one of the next steps that we'd like to expand this to, where there would be an integration with education that we know is underway in terms of development at CHEO by your specialists to help parents learn exactly how to manage their kids' inhalers or asthma, monitor their symptoms, know when to seek care. And because this would be part of the primary care platform, the primary care clinicians would be exposed to this as well. And it could help with their own understanding and learning. So how exactly that would be implemented in a way that does have impact on the clinician side, we would need to work with experts around the implementation of that to achieve that. But that is something that we have thought about and talked about. And asthma is, I think, a piece of low-hanging fruit in terms of resource-intensive appointments that require a lot of education and counseling for the parent, that require the clinician to be up to date with the changing landscape of evidence, and that has the potential to reduce the strain on other sectors of the system, like respirologists, emergency departments, for example.
We'd be happy to help with that.
Thank you. That's great.
Okay, Lee, we'll go to you next, and then we'll just do as many of the chat questions as we can at the end, and we'll aim to wrap up in about 4 minutes. So, Lee, go ahead.
Yeah, video won't start, but thanks, Kamila. I have two areas. One is, can you hear me?
Yes, I can. Thanks.
Okay, great.
We all can.
One is to include, I like the comments about evaluation and to include in there the time workflow elements. It's extraordinarily important. We anticipate that it's time saving sometimes, but sometimes it's better quality, but still takes a lot of time. And on the time part is also to understand the time for the patient or the family member who's doing this work. I've been doing two-way email for more than 14 years. Most colleagues had said I was crazy, but that's true. But it was extraordinarily helpful for me to be able to run my practice. And there's an awful lot that gets revealed by two-way email. We have these tools now integrated into most of our electronic health records. And we also have capabilities from within each health record to use large language models and other AI type technologies internally. To me, our real question as a community of practices is to look at how will we share data out. So will it build from a platform from within individual people's EMRs, or will it be something applied externally? The templated messages, many of us in family practice are doing this already. So I am keen to see how these things could get personalized so that we're getting into sharing of data, but not necessarily brand new workflows for what we've already found to be effective. So I am curious as to whether you've incorporated any things about time workflow studies for the clinicians and this idea of, are you looking at a single external platform or something that's internal that gets applied within each EMR?
Thanks, Lee. Great question. So part of our needs assessment is to understand exactly what's already happening in the community and to make sure that what we're going to do is going to improve on it, not duplicate it, not make it worse. So we want to definitely know what exactly is happening already. Our clinic has Ocean already as well. We have not activated the automated appointment detection feature for appointments, and we've noticed that the questionnaires available in Ocean don't quite meet the needs that we have for things like well baby appointments. They meet part of it, but not all of it. So we plan to improve on that, for example. And then in terms of your question about the sharing of data outward, I think that you were asking about whether or not we would be sharing data to a centralized database, or maybe you can clarify your second question there for me.
Right now, within my practice, if I train my scribe to give me the data that I wish, I can get it. So I can train it with questions. So many of this internal stuff I can do, but if I want to ship data out, I don't have an easy way to ship data out, for example, to a anonymized centralized database that I can be the contributor to it,
Right.
but I could still have it personalized for my practice as what seemed to work for our workflows.
Yeah, so I would encourage those on the call who are interested in contributing to centralized data sets using your EMR data to reach out to Doug Archibald, who's here today, who is the director of Open, which is a primary care-based, practice-based research network that also feeds into another entity called Poplar that runs this for the whole province, and that's led by Lisa Jackamanian out of Toronto, but headquartered at Queens. And what they do is exactly that. They collect EMR data from practices that have consented to have their data collected, and it can be linked then to ICES data. So there's that opportunity there to collaborate with Open, and I think that what you're suggesting flags for me that we need to make sure that the format in which we collect the data from these tools that we're looking to implement are amenable to integration at a third-party level.
Yeah, thanks. We had like half an hour for discussion. Looks like we could have had another hour and kept going. I do really want to encourage on this last point to connect in with Alicia at Bourne. This is work that's already also been in play for a long time in terms of integration with the EMR and as a prescribed registry to facilitate and improve care. Data could also flow in specific use cases without consent. And so that's where the screening examples are really relevant. So both in terms of the infrastructure that Bourne has created provincially, but also in terms of some of the anticipated uses, I think it's really important to make, that's a big connection for me out of today, is to connect Alicia with you. I had wanted to, yeah, yep. Yep, we're at 9:30. I was just trying to quickly see if there was a very quick question we could take within the chat, but I think what we'll have to do is summarize the chat and get all the questions from the chat and share them with you along with the people who asked the questions, because I really want to ensure that we made the connections out of today.
Yeah, and if we can put the emails for Bill and I up again, we'd invite you to reach out to us by email as
So
well.
Rachel, if you can put the slide back, oh, I have to do that? Okay. Okay, we'll send it out, actually. We always have a post rounds evaluation, so we'll send the emails out with that as well. Okay, with that, we're going to wrap up 1 minute late. Thank you very much. And thanks to everyone online. We will collate all your questions and get back to you. I can't figure out how to turn the, oh, here it is.